Okay, so I'm going to tell you about a lady who's a 52-year-old lady who has been amenorrheic for 9 months, and she does have some night sweats, and she has quite profound irritability. The husband told me that. She also has some other interesting symptoms where she finds that sort of in the middle of the morning she'll suddenly feel a bit shaky and lightheaded and gets very sudden fatigue, and she describes it as if somebody's just pulled the plug out on her, they switched the electricity off. She has sugar cravings, and she's been gradually gaining weight over many years. And there's a family history, a relevant family history of coronary heart disease, in that her mum had a myocardial infarction at the age of 62. So we look at her, and she is obese. She's got a BMI of 32. She's got an increased waist circumference, so she's got central obesity, and she's got somewhat of a raised blood pressure. So the investigations we did, fasting lipid profile, fasting glucose, and a fasting insulin. And the reasons for doing that, obviously, is because she's got symptoms suggestive of hypoglycemia, which is often the typical symptoms of somebody with insulin resistance. So particularly mid-morning or mid-afternoon, feeling a bit lightheaded, but this sudden fatigue is absolutely classic in patients with insulin resistance, and she's got sugar cravings, and she's overweight and whatnot. So we've done these investigations, and here's her lipid profile. So she's got a slightly raised LDL cholesterol, she's got a bit of a low HDL cholesterol, and she's got raised triglycerides. So that's obviously an abnormal lipid profile, and that would fit in with her eventual diagnosis. I've done that before, that's for the sake of time. Look at her glucose. So she's got a normal fasting glucose but she's got a normal insulin, but if you calculate her insulin resistance index, it's actually elevated. So she's got evidence of insulin resistance. Okay, so what can we do about that? Just to remind you that estradiol is good for improving insulin resistance, and the androgenic progestogens are not very good news if you've got insulin resistance. The diagnosis of metabolic syndrome is now made, and this is a unified sort of diagnosis now. So an increased waist circumference, fasting glucose above 5.6, low HDL, raised triglycerides or raised blood pressure, any three of that lot, you can make the diagnosis of metabolic syndrome. And you'll note that we have different values for the United States than from the rest of the world, because if you had the sort of normal values for the United States, they'd all be insulin resistant. So the diagnosis is made, she's got metabolic syndrome, and what we did was to start her on HRT, because she's got some menopausal symptoms. She's got her irritability, which needs to be sorted out. We start her on oral estradiol, 2 milligrams, plus cyclical dydrogesterone, and get her to go onto a low glycemic index diet, which is important because that itself will help in insulin resistance. And we're telling her to have a low-fat diet because of her elevated LDL cholesterol, and most importantly, a low-salt diet, because she's got slightly raised blood pressure, and it's so important to remind patients not to add salt to the food, and try not to cook with too much salt, or use potassium chloride rather than sodium chloride, because reducing salt intake will reduce blood pressure to some extent. So, follow her up 6 months later, and she's actually lost 6 kilograms in weight. So she's the one patient in 50,000 that actually takes notice, and if you tell a patient to lose weight, they usually respond by gaining weight, in my experience. Her night sweats have gone, her irritability, she's no longer irritable, but she still has these mid-morning feelings of sudden loss of energy and a bit shaky and whatnot. So she's still got some symptoms relevant or possibly related to insulin resistance. Her BMI is still elevated, but she's now overweight rather than obese. Her waist circumference is still elevated, but it's come down a bit, so she's lost some weight centrally. And her blood pressure has come down a little bit, but is still not fully controlled. Her HDL cholesterol has improved, her LDL has improved, but her triglycerides are still a bit elevated, and her insulin resistance index is now normal. So, because of her symptoms, we've started on metformin as well as the HRT, continue on the diet, and starting her on slow-release metformin, 500 milligrams a day, and then increased it every 2 weeks till we get her on a standard dose of 1,500 milligrams a day. And she loses a further 6 kilograms over the next 6 months. Feels very good, feels very well, much more energy, and now all her symptoms have gone, including the symptoms of hypoglycemia. Her BMI now is almost normal, not quite, but that's an amazing improvement to what she was. Her waist circumference is almost normal, and her blood pressure is almost normal. Her lipid pattern has improved further. Her LDL cholesterol is now normalized, her triglycerides have now normalized, and her insulin resistance index is now very normal. So the management plan here is to continue her on HRT with annual reviews, and after a couple of years we plan to change her onto a continuous combined HRT with estradiol and dydrogesterone, because she's happy on that. And we continue on metformin until her waist circumference was actually normalized, and then try withdrawing it. I mean, there's no hard and fast rules for doing this, it's just you do it on an individual basis, but that would be the plan with her. So, one happy lady.
Can I ask a question?
Yeah.
Why she didn't start metformin on the first visit? Did she have any indication to start metformin on the first visit?
Because it's possible that she could have completely normalized things just with the HRT. And so we only added metformin when it was clear that she hadn't managed to normalize things with the HRT. So, you know, sparing taking an extra medication. I mean, metformin is a very safe drug, but some people do get side effects, particularly gastrointestinal side effects, yeah. Yep.
Do we need to do a triplex in the carotid in such a patient to see if there is a cardiovascular disease before starting HRT?
No, I wouldn't do any investigations before starting on HRT. And if you did any form of cardiovascular imaging, all you're going to do is possibly reassure the patient, or more likely frighten her. Yeah. Because you're doing all the right things anyhow. If she's got early cardiovascular disease, the HRT will help, but it won't help her knowing about it. Okay. Yeah.
If she cannot tolerate metformin, what would be your replacement metformin?
Yeah, it's a difficult one because, what insulin sensitizer could we give her? I mean, I wouldn't like to use the thiazolidine because of the risks from them. I would personally probably try her on acarbose. That would be my personal preference. Totally prejudice-based, not evidence-based, but that's what I would do. Shall we go on to the next one? Or should I leave it there?
I think we'll have time now, 10 minutes. And then,
Do another one? Get it second case?
but I think if you can just stop and ask the audience what they do, just to have it a little bit more, it will be more fun, isn't it? Just to ask them and,
Well, it'd be more fun if they answer. Okay, so this is a 46-year-old lady who is premenopausal, and she's getting central chest pain on exertion, but she finds that she only gets these symptoms in a week or so before her menstrual period, but they become so severe just before menstruation that she actually gets admitted to hospital virtually every month. And this was actually happening. Of relevant past history that she had a deep vein thrombosis, but this followed a fractured tibia in a road traffic accident, and she was on the combined oral contraceptive at the time, but she does have a family history of venous thromboembolism. Normal BMI, slightly increased waist circumference, normal blood pressure. which investigations should we do? Any? All of them? Yeah. So, I mean, she's got the reason for doing a lipid profile and a glucose and insulin would purely be because she's got some evidence of central obesity or increased central fat. A resting ECG coagulation screen, is that worth doing? I mean, she had a deep vein thrombosis, but she had every reason to have a deep vein thrombosis. She had a fracture, she was on the oral contraceptive pill. So would we just be wasting money doing a coagulation screen? Possibly.
Can I ask something?
Yep.
If we were to do coagulation screen, what kind of coagulation screen would we do?
Well, in 3 slides' time, I'll show you.
But I think that's important.
Yeah.
Because, I mean, you know, let's say she had a fracture, spontaneous DVD. So you suspect she might have some.
Yeah.
What would you? I mean, what kind of screen would you do?
Well, basically, we'd screen for the things that we know about, because we can't screen for things we don't know about.
So factor V Leiden?
Factor V Leiden, the prothrombin gene mutation, and any others that you...
Protein C, protein S?
Protein C, protein S, antithrombin.
And that's it, huh?
Yeah.
That's it. Not all the other 25...
No, well, your screen, basically, your screen would be whatever your hospital is capable of doing.
Oh, they're capable of doing a lot of things, and then we...
All right, well, in the UK we have something called the National Health Service, and they're not capable of doing a lot of things. So there's her lipid profile. She's got a slightly raised LDL, but she's got such a good level of HDL, so that the LDL increase is minimal. Normal HOMA score, so that's all okay. So this is the thrombophilia screen that we actually did. The other thing we did was the antiphospholipid antibodies, which may or may not be worth doing. But everything was negative. That doesn't mean to say that she hasn't got thrombophilia, of course. It just means that you can't detect that she's got one. We did a resting ECG, which was normal, and as was pointed out earlier, that tells you absolutely nothing, because you can have quite severe coronary disease and have a normal resting ECG. But because of her angina, it was worth doing investigation, so we did a CT angiogram, which is sort of non-invasive, and there's no blockages of the main coronary arteries. We did a cardiac MRI perfusion scan, and this is a way that you can actually pick up microvascular angina. And what she's got here, subendocardial hypoperfusion, is a classic MRI finding in patients with microvascular angina. So that's her diagnosis. She's got microvascular angina, and the reason that she gets the exacerbation in the luteal phase of the cycle is because that's when her estrogen levels are falling. And so what we try and do is to give her a top-up dose of estrogen prior to menstruation and see if that helps her symptoms. So we start her on transdermal estradiol, a 50 microgram patch. Just tell her to stick the patch on when she starts feeling the angina coming on, and keep on with it until she's about 3 days into her menstrual period, and then she can stop because her symptoms will have gone away anyhow by then. And we gave her a low GI diet purely just to help with the...
Can I ask something? If the angina, and I have no idea about cardiology or anything like that, if you attribute her angina to dropping lows of estradiol, shouldn't she have a recurrence of her angina when you stop the patches? You have a more rapid decrease of estradiol?
No, because her own production of estradiol is then increasing.
When? No, it's not increasing. When when they are in their periods, the estradiol levels are very, very low. Like in the day 20 of their cycle, the estradiol levels might be around 80 to 100 picograms per ml, but in the first 4 days of the cycle, they are less than 50 in a normal cycle.
But they're starting to come up.
Yeah, no, but I mean the drop. I mean, don't you have an increased drop when you take off the patch, and then they have the?
Yeah, yes, indeed, you do.
That was my.
Yeah, you do, but it doesn't seem to affect her angina, and we find that it's a fairly consistent finding that 2 or 3 days into menstruation, because normally without the estradiol patch on, her angina goes away anyhow 2 or 3 days into her menstrual period. So that's the idea of doing it. So 3 months follow-up, and she's not had any further hospital admissions, which is a good result. Her angina has improved, but it's not abolished. She still does get it. So the patch didn't relieve it completely. So what we tried to do was to sort of thought, well, if we stop her ovulation, then she's not going to get the same hormonal fluctuations. So we gave her an combined oral contraceptive. In this case, it was ethinyl estradiol and drospirenone, and told her to take it continuously without any break, hoping that that should stop the fluctuations in her hormone levels and that should stop her angina. Unfortunately, it didn't work. She's actually getting more angina, but she still had some cyclicity of it, so probably the oral contraceptive pill wasn't suppressing her ovarian function significantly, or sufficiently rather. And so what we did was to give her a medical menopause and put her on a GnRH agonist using goserelin once a month and give her continuous transdermal estradiol norethistron as an add-back. So we did that, and it actually had very good effect on her. So 6 months later, she feels really good. She's had no angina whatsoever. She's amenorrheic on the combined patch, and she has no menopausal symptoms. So we're doing, that was fine. That was a really good job. And the cardiologists stand back in amazement and think, how the hell have you cured her angina? We used estradiol, and cardiologists, estradiol, is that estradiol 17 beta blocker?
Like, were you going to continue with the analogs after 6 months? You see, that's another issue. With what are you going to do with the analogs?
When do we stop? That's the question. When do we stop? Well, let me just tell you, 2 years later, we kept her on, and because she's so good, but the angina is starting to come back again. So now what we do is to give her one of the anti-anginal drugs that we use, particularly for microvascular angina. Put her on ranolazine. That's my drug of choice for microvascular angina. Otherwise, a long-acting calcium channel blocker would be the other alternative that we would try. But ranolazine worked very, very well with her, and her angina almost completely resolved with that. So that's the treatment she's on. When do we stop? Do we just keep her going until she gets to the age where we think she'll have gone through the menopause anyhow, and then we can stop the GnRH? I mean, it's.
But now if she's taking that, don't you think you should try stop everything else and just keep you on ranolazine and see what's going to happen? Because if she's happy with ranolazine, why should she get injections, GnRH analogs, which is like 600 pounds every 6 months, whatever it is, plus plus birth control pills, plus ranolazine. If ranolazine works for her angina, why should she get...
But it's working on top of the HRT add-back.
We're not sure. We have to discontinue, then we'll figure out.
So if we could try, you could try discontinuing the
slowly,
HRT.
do like a washout period.
But then if her angina comes back, when you do that,
we'll
she'll be very unhappy. So, she's happy on the HRT. I would just keep her on it. It's great stuff.
Interesting case. Very interesting. Yeah.
If a woman had macrovascular disease, coronary artery disease, would you do the same?
I personally probably would do the same. All the cardiologists would say, oh my God, she's got coronary heart disease, you can't give her HRT, which is absolutely nonsense. And that's because cardiologists, A, don't understand hormones, B, often don't understand much about coronary heart disease.
Why not Mirena device and continuously transdermal patch?
You could.
Why put the young woman on iatrogenic menopause?
You could give her the Mirena system.
But what about the bone density?
Well, if she's on the GnRH analog, then you need to keep her on HRT to preserve her bones.
Yeah, but we have a woman with 2 regimens when we can just put a patch and put a device for 5 years. Why?
Why not use that?
Because it's easier and it doesn't have menopause.
I'm not quite sure I understand your point.
I think what she's saying is that if you can keep you on a continuous estradiol regimen, put the Mirena, so you don't care about giving any additional progesterone, so you have an atrophic endometrium, and they do not give GnRH analogs, and see how it's going to work. So you have a steady state estradiol levels.
But if she's not on a GnRH agonist, she may not have a steady state.
She has
If she's still premenopausal.
Yeah, but we have progesterone, progestin and estrogen, so
So that's just as easy. Sticking a patch on is just
it's
as...
like continuous contraception.
No, it's not contraception. Just using the patch itself is not contraceptive.
Yeah, but
But if she's on a
explaining
GnRH
before.
agonist, she's not going to get pregnant anyhow.
Yes.
So she doesn't need contraception.
Okay, take away the pregnancy. I don't understand why we initiate the GnRH analog.
Why we did that?
Yeah.
Purely to stop any fluctuations in her estrogen levels, which I believe were triggering the angina.
But on
We have the exogenous estrogen and progestin, and we care more about the endogenous.
Yes.
So we
It's
stopped,
more potent from the exogenous use.
but we stopped her endogenous estrogen production, and giving her exogenous estrogens keeps it at a level. It doesn't fluctuate.
Which is more potent?
I think
this
I
case.
think the question is whether the exogenous estrogen suppresses the axis.
Yeah.
That is your question, right? And I agree with you that if you give exogenous estrogen, especially in a form of a patch, you might have a good suppression of the axis. But apparently, there's not enough suppression. You have to give an additional GnRH analogs. Is
Yeah.
that right? Okay.
Well, yeah, but she was premenopausal, so you wouldn't be giving her a continuous combined HRT to a premenopausal woman.
No, I understand that. Okay. So, next question. Sorry, we don't want to monopolize going to a dialogue, so we have more people getting there.
Sure.
Good morning, Alessandra Graziotin from Italy. Thank you, John. 2 questions. Why did you prefer natural norethisterone instead of natural progesterone? And do you have any experience with the HEA, 10 or 25 milligrams in these patients? Thank you.
Okay, thank you, Alessandra. We used norethisterone because it comes in the patch. So, if you don't have a patch for natural progesterone, I mean, if you did have a patch, it would start at your chin and end at your ankles. So,
Yes, but we can have the patch with estradiol and the natural progesterone in the vagina.
yeah,
So,
you could certainly do that. But
And the effect on the vessels is more physiologic in comparison to norethisterone. So this was why I would have given transdermal patch, certainly, plus progesterone, natural progesterone in the vagina. But I usually test the HEA and I add back the HEA. And I think this is a powerful compounding by the pharmacist, not the over-the-counter story of the normal shops, but qualified the HEA, and this translates into all the children hormones, as I explained to my patients, so progesterone, allopregnanolone, very important in these patients, and it reduces cortisol, that is the marker of pathological aging. So I think that we should consider more in our practice, certainly what you did very well, because she's premenopausal, I agree 100%, but also consider this androgenic supplements that we are still neglecting in our daily practice. So that's why I appreciate your comment on that.
yeah, I mean, I have no experience with giving DHEA to patients with angina, so I haven't a clue whether it would do any good or any harm or what. As far as this patient's concerned, we just want to keep the medications as simple as we can, and it's complicated enough giving her a GnRH agonist anyhow, but it's expensive as well. But then again, having a hospital admission every month with angina is also expensive.
Actually, I think it was a really interesting discussion. I would appreciate if the speakers spend some time with the audience, but I want to move on a little bit more. And I think then the next case will be it's an prevention of endometrial and ovarian cancer. It's going to be. Thank you very much for the. These will be fast.